Good morning, everybody, and welcome to this very special webinar. My name is Louise Gittins. I'm leader of Cheshire West and Chester Council. The webinar is entitled Health in All Policies, Leading Place to Tackle the Social Determinants of Health. We've got an hour and a half to discuss this important issue, and I'm pleased to say we've got 5 fantastic speakers. We are expecting 200 people who've registered today to be attending, so hello everybody. If people haven't been able to attend, we are recording today's session, so it will be available on the LGA website, as will all the slides that you'll see today. So just running through the order of events, we're going to hear from our speakers, and then at the end there's a chance for everyone to ask questions. So if you've been on one of these before, or this is the first time, there's a Q&A function on your screen. Please submit your questions, queries, observations, comments, and everybody else can like them, and then they move up. So the more likes that you've got, the more likely that your question or observation will be read out, and we'll do those at the end. If you're on social media, Twitter, Facebook or whatever, the Twitter hashtag is hashtag LGAHiAP. The coronavirus pandemic and the subsequent measures to control the virus have really shone a light on existing health inequalities that many in our communities experience. People facing the greatest deprivation are experiencing a higher risk of exposure to COVID-19, and existing poor health puts them at more risk of more severe outcomes if they contract the virus. Local government leaders have been doing their utmost to support the most vulnerable to coronavirus and keep all of their communities safe during the pandemic. However, we know that in the difficult days and months to come, we will need to do much more to tackle the deeper causes of health inequalities. So we want to take this opportunity to build a fairer, healthier, happier society by influencing the social determinants of health. This panel webinar will explore how local authorities across the country are leading this change by embedding a health in all policy approach to their work. This webinar builds on our previous events on COVID-19 and ethnicity, and using Marmot principles to tackle health inequalities. It is part of our ongoing work in the LGA to support councils in their commitment to ensuring that no one person in their community is left behind by the effects of this dreadful disease. So that's all from me, and let's get on to our speakers. And the first person I'd like to introduce is Alan Higgins. He's an LGA associate and former Director of Public Health for Oldham Council. Alan, over to you.
Thanks very much, Louise, and good morning, everybody. I always hear that title, former something, which just kind of says, and he used to be important. Anyway, so, what I'm going to do, I'm going to share my screen so that you can see the slide set that I'll be using. And I'll get that onto slideshow from the beginning. So hopefully you can see that it's the Health and All Policies, and that we're here to launch the LGA's workbook. And what I'm going to do is talk about the concept of health and all policy through a few slides, and particularly pick out what it means to me and why it's important to me as a public health practitioner. Then I'm going to switch into a different share screen, and stick with me, the tech will work, where I'm going to leaf through the workbook just to pick out some highlights from it. Then I'm going to come back into my slide set where I'm going to talk about work that I'm doing in my current role as Head of Programme for Public Health England in Liverpool City Region, where I'm going to look at the Wealth and Wellbeing programme that we've been implementing there for 3 years and relate that to the Health and All Policies approach. So that's what I'll be covering in all of 15 minutes, and then we can come back to questions at the end of the session. So, health and all policies, strongly advocated by World Health Organization and adopted worldwide. And it is, I've seen approaches to health and all policies set out when I've been on a conference in New Orleans about 5 years ago, where it was the American Public Health Association. They were talking about health and all policies approach and had some significant guidance on it, and it's across many areas in Europe and in other parts of the world as well. Originated in Finland. I think the concept was developed there, and this statement is from World Health Organization Helsinki Statement on HiAP in 2013. So it's an approach to public policies across sectors that systematically takes into account health implications of decisions, seeks synergies of joining up with other policies, avoids harmful health impacts in order to improve population health and health equity. And for me, it's about putting health at the top of the priority list when we're looking at all of the policy decisions that happen through local government and beyond. And saying that what we need to achieve and prioritise and look at is how these different policies relate to health, how they will help to achieve health and well-being, and what that means for economic policy, for environmental policy, for traffic policy, and so on, and transport policy. And that's why health and all policies is important to me. It gets that health and well-being focus into each of these other policies that don't necessarily have health as their main reason for being. This next slide picks out 7 key benefits of a health and all policies approach. First one here, promoting health, equity and sustainability. Equity, of course, is very much in the news since the impact of the pandemic, which has actually highlighted existing inequalities. Sustainability, very important here, particularly when we're hearing so much at the moment about threats to biodiversity, about climate heating. And I think that the link between promoting social and health and well-being and environmental well-being is a key one for us to address through a health and all policies approach. Next 4 points, I'm going to group together because that's all about partnership working. It's about engaging stakeholders. And that's a key aspect of a health and all policies approach, is that you reach out beyond what might be the usual working partners and you try to find others through a health and all policies approach. And the whole approach is geared to actually taking on board other perspectives and then looking to see what the health impact of those perspectives actually are. The next point is that it's the 6th. Create structural or procedural change to embed tackling health inequalities. That's a key one as well. Because what we're saying is that with this health and all policies approach, what we're looking to achieve is long-term structural procedural change. It's not a short-term putting health at the top of the agenda for 3, 4, 5, even 6 months and then moving on to something else. It is about creating the structural or procedural change which sees the health and well-being as being the priority that we're looking at all of the policies to actually address. Final point there is about developing common monitoring and evaluation tools. It's important we know whether we're having an impact. So this next slide is one of my favourites. It comes from work that was published in the BMJ in 2017 by Ben Barr and colleagues, a lead public health researcher from University of Liverpool. And I'll just take a moment to explain what it is that we're looking at. So up the side here, we've got life expectancy, 70 to 85. And along the bottom, we've got years from 1982 to 2016. And up this side, we've got the gap in life expectancy between the blue line is life expectancy in the 20% of the population living in most deprived local authorities. The green line is the population living in less deprived local authorities. And if you remember, policy from over the years is about how we close this gap between the blue line and the green line, going from 82 onwards to about 2016. The red line here is a measure of how that gap is changing over that time. So the red line is going up as the gap between these two lines is getting larger as well. So you can see that the gap in life expectancy as a measure of health inequality is increasing throughout the 80s, throughout the 90s as well. And then during this period that's shaded here, which is when we had a national health inequality strategy, you can see that the increase stops and then it starts to come down. You can see the gap between these two lines is closing as well, narrowing at least. And what I take from this is that during this period when we had a structural approach to health inequalities, and this coincided with when I was a Director of Public Health in Greater Manchester, and we had a focus on those areas which particularly had large gaps in health in life expectancy. But when we had that structural approach, when we had that focus for that period, we were actually able to have an impact. And that's what I'm wanting to send as the message through this work and this presentation, is that if the councils can actually have that structural approach which is sustained, you can, I think, have an impact on health inequalities. Otherwise, it can seem as if it's something which is just there and is always with us. But if you actually have that focus, you can make that difference. So now I'm going to change. So back to me for a moment while I stop sharing those slides. And then I'm going to share the workbook. So what you should see on your screens now is the opening page of the workbook that we're launching today. And I'm going to assume that that's what you can see unless anyone speaks up and tells me different. So first point, I'll just leaf through a few bits of this. First of all, it is a workbook. It's got questions in here. It's got spaces for you to fill in your responses to those questions as well. And it is about a workbook to help councillors work through their understanding of health and all policies and how that might be applied within their borough. I'm going to leaf down through a few pages here. This one, I'm going to make this a bit larger. This is the contents page. So we've got a recap of the health and all policies approach. Before that, we've got a summary of what the emerging key issues are. Then we've got this important section, because this is about updating the health and all equalities workbook from the LGA to take account of COVID-19 and health inequalities, the impact of the virus, and so on. And then looking at the response of local government to COVID-19. I'm going to highlight a few other parts. And here, if you're familiar with LGA booklets, workbooks, you'll know that there's a good key here which highlights the various things that might well be a challenge. This is where you'll get questions asking you to think about how health and all policies might be applicable in your borough, asking you to find out things about, say, the impact of COVID-19 in your borough as well. I'll move on to page 6, which is this part where we have the emerging key issues for leading members. And I'll just highlight a few things here. Nature of the COVID-19 emergency and long-term implications. The balance between immediate response to pandemic COVID, to recovery, and about building a better new position. So that is about just saying that immediate emergency response is different from what you might think about a recovery plan, and then what you might think about where you want to get to, building this new position. And there's a section here about the unequal impact of the virus and the response to it. And this section is summarising what is then explored in more detail as we go further through the booklet, the workbook. Here's one of the challenges. So it sets out a question and then asks you to fill in, if you're a councillor working in a particular area, what your response to that would be. I'm going to move down to page 11, because of course case studies are key when we're looking at trying to make something very practical, to make a very practical understanding of health and all policies. And throughout the booklet and throughout this presentation this morning, we'll be hearing from councillors who have been applying this approach within their borough. So there's something here about Southwark, there's something further on about Newcastle, and so on. So the booklet, the workbook, does have these case studies within it. And I'll move down to page 15, just to highlight, this is the part where we've picked up COVID-19 and health inequalities, impact of the virus. And moving further down, section talking about, well, there's a challenge. What has been the impact of COVID-19 in your borough, in your council? Response of local government. There's an interesting section here about the new normal and what it would be like functioning in a COVID present world. So that's kind of saying, well, we talk about COVID present because we think there's probability that COVID-19 will always be here, perhaps a bit like flu returning each year, and that we need to take account of what that might mean for us too. So, so that's what's in the workbook, and that's the point of what we're looking to launch today. I'm going to stop sharing in that, and then I'm going to share with a final few slides to talk about the work that we have been doing in Liverpool City Region. So if I can get this right, current slide, there we go. So Liverpool City Region Wealth and Wellbeing Programme, I've been working for 3 years. What we've done in that time, it has been looking at wealth and wellbeing, so work and health and economics and health. And some of the work that we've done, we linked poor health to the productivity gap in the Liverpool City Region. So we could explain about a third of the productivity gap between Liverpool City Region and the rest of the country was attributable to ill health, particularly mental health. We engaged widely with the public sector, voluntary sector and communities on economics and health, built an evidence base, created a narrative based on views of people unable to work through ill health, and proposed a plan focused on 3 points: employment support programs, reform of the workplace, wellbeing economics. Why this is relevant to health and health policies is that it's this part here about engaging widely, drawing in different perspectives. It's also this part about looking at economic policy and drawing out the health implications of economic policy. And then what we're looking to do is to develop that further, to say how we could actually change economic policy to have a particular focus on well-being. So it's not an explicit health and all policies approach, but health and all policies is going throughout this work. Next slide, just to add a bit of colour to the presentation as well. I wouldn't want to overstate this, but we did go out of our way to connect with new perspectives through this work and continue to do so. So the system connection workshops is something I will keep coming back to. And again, for me, that fits with the health and all policies approach, that part about engaging, reaching out, finding new stakeholders, drawing more people into the consideration of health and well-being as a priority issue. And then the last slide, just the key message that has come out from that work so far. Highlighted in yellow, an economy that functions effectively for everyone is better for health and well-being, and a population with better health and well-being is better for an effective and fair economy. And that may well sound like a truism. I mean, who would disagree with that? But what we're doing through this work is saying that that needs to be taken on board, thought about, and then we need to look at how that might well change our approach to economic planning. Where we're looking to take this work forward in the next few months, developing a joint approach to reform of economic planning, combines and prioritises environmental, social and health outcomes with inclusivity, sharing and networking across combined authorities, and then recording our experience. And it's this bit here which particularly relates back to health and all policies. It's about looking at policy on economic planning, but drawing out the priorities around health and well-being outcomes for that economic policy. So I'll stop sharing at that point and just sum up by saying it's about launch of the workbook. The workbook has some challenges within that should help you to apply a health and all policies approach within your borough, at least understand how you would go about doing that, and emphasises that we're looking for structural and procedural change that is then sustained over the longer term. And I'll finish there and happy to come back to answer and respond to questions later on. Thanks very much.
Thank you very much, Alan. That was really informative, and I'm looking forward to working through the workbook myself. So could I now hand over to Councillor Tim Hutchins, who is a Cabinet Member for Public Health and Prevention at Hertfordshire County Council. Tim, over to you. Tim, you're on mute. If you'd like to unmute yourself, sorry.
How's that? Is that okay? We're having all sorts of technical problems this morning. Not least of all, I don't know how to unmute myself. There we go. Good morning. First, I'd like to thank you all for the invitation to speak today. When the invitation came through, I have to say I was delighted, but a little questioning as to whether you got the right person. I've been a Cabinet Member for Public Health and Prevention in Hertfordshire since January 2019, and confess that when I took on the role, I knew nothing about public health. 20 odd months later, I maybe know a little bit more. I say this not to highlight my own shortcomings, but to emphasise the need for getting the message out there, loudly and clearly, that health factors are a vital ingredient in horizons of wellbeing. From that, I hope you will recognise that I'm very much in combat, and hope to briefly make the case for health in all. For almost 20 years before becoming an active member.
Tim, we are struggling a little bit with your sound there. It's not coming through very clear. So what I thought we could do is, if we move on to the next speaker and then come back to you, if you can have a bit of fiddle round and perhaps speak to one of our team to see what we can do to improve it. Is that okay? Because it's just really quite distorted. Okay, so if we can move on to our next two speakers, which is Grant Taylor, who is the Head of Culture and Health, and Councillor Andrew Gordon, Health and Wellbeing Partnership Chair from Basildon Council. Thank you.
Thank you, Councillor. And thank you, everyone, for letting us speak today. I'm going to use the immortal words. I'm going to share my screen, and then I'm going to look for assertive nods that it's working. Can people see my screen? Excellent. Okay. So bit of a double act today between myself and Councillor Gordon. We both here from Basildon Council in Essex, and we're going to speak you through some of the work that we've been doing as an organisation in relation to this important work. So yeah, just to start off, I'm Grant Taylor. I'm the Head of Culture and Health at Basildon Council. And Councillor Gordon, do you want to give a quick hello to start with?
I'm Councillor Andrew Gordon, and I'm Vice Chair for Health, Housing and Communities, and Chair of the Health Board in Basildon. It's a real pleasure to be here today and speak to everyone.
Thank you. Okay, so our presentation today, I'll tell you what I should be doing, is I should be putting that onto slideshow, shouldn't I? Apologies, everyone. From the beginning. There we go. So we're going to be talking about something that we have been calling the health lens, which hopefully will make sense as we manoeuvre through the presentation. But in essence, sets out kind of how we try to take put health, the lens of health on many of the decisions that we make. So I wanted to start off by just setting out, I guess, what is the vision and the priorities under our health and wellbeing policy and strategy. So obviously, about reading piecemeal here, you'll see our wider vision to enable residents to live long, healthy, independent and happy and active lives, and with a series of priorities. I think importantly for today's presentation to point out where we are with priority number 2, which looks at improving mental health and well-being. So all of the priorities are interlinked and are as important as each other. But I know that one of the things we were asked to talk about today following as being used in a case study for the Centre of Mental Health in the LGA paper recently was in relation to mental health. So Councillor Gordon, I'll pass over to you for these next few slides.
Yeah, so I mean, we could spend hours talking about governance structures in local government. I think the important thing is Basildon is not, we don't have a statutory health, we're not the statutory health authority, we're a district council. I think over the last 5 or 6 years, we've really changed our view that even though we don't have a statutory duty for health, health is absolutely essential to every single service that we run. A little sort of anecdote is a few weeks ago in our health board where we was discussing COVID, we're discussing some of the impact of COVID. An officer with responsibility for waste and recycling came and spoke to us and said, you know, we're noticing an increase in the amount of glass bottles being, you know, put out. What's going on with that? You know, it's going up by 30%. What are we going to do? Are people drinking more? You know, so it affects every part of our business, from waste and recycling to housing to environmental health. It comes into everything we do. It's a core part of our business. Just moving on in terms of why I think, and I'm maybe going to be a bit contentious here, I think actually district councils are better placed to look at and address some of the social determinants of health. If you think about it and you think in terms of the opportunities, Grant, if you just move on to the next slide, you know, district councils tend to be close to the community. They tend to have local intelligence, that local insight into what's happening on the ground level. You know, we're the ones that engage often. We're the ones that are there with those connections, and I think that's been the most important thing for us in Basildon, is building those connections and looking for it all in a health lens. So even though there is complexity to having that two-tier governance, I think for me, as the lead member on this, I see so much opportunity in us being a district council and tackling this health and wellbeing agenda. And I think if I think about our health journey in Basildon, and if, you know, Grant, if you just move on to the next slide, and I think about sort of where we've come from, I think for me, I became a councillor in 2011, and, you know, not a public health expert, not sort of a health expert by any means, but one of the key things that I did as a councillor, every single meeting I went to, I said, what are we doing about health? How does health affect this? In fact, often I would challenge myself to go to a meeting where it was completely unrelated to health and wellbeing and say, well, what are we doing about health? And over the years, officers within the council got to know that Councillor Gordon's going to come along to a meeting and he's going to talk and ask us about health and wellbeing. You know, we talk about structures, but I think, you know, looking at health, looking at the social determinants of health, it's almost a culture change that needs to happen, because it's not just a process, it's a mindset. It's thinking about health, it's thinking about how the decisions we make as a local authority are going to impact on people's health and well-being, and that's absolutely crucial. One of the things that was really helpful for us, actually, and again, Grant, I'm not sure we're on the next slide yet, if you just move on,
sure.
Was when we appointed a public health practitioner in 2016. You know, having an officer in a district council that had that portfolio was absolutely crucial to us. Then we got the sort of strategic buy-in. We got our first health and wellbeing policy released. You know, that was a massive achievement, really sort of set the groundwork for things to come. We had a refresh of our local health and wellbeing partnership. You know, thinking about what partners we had around the table, not just the usual suspect, but actually let's invite the police along, let's invite the youth service along, let's invite social care along, let's invite, you know, care providers along. Let's make sure people around the table are not just typical people we go to talk about health. You know, let's engage with taxi drivers, let's engage with barbershops. You know, that's what we want to do. That's our approach, is about engaging the community, engaging the people that are on the ground. And that's not necessarily the local hospital. That's not necessarily the local CCG. So refreshing our health board and refreshing what we did in Basildon and our sort of strategic aims is quite key. And then one of the biggest achievements for me, thinking about what we did in Basildon, was actually getting health and wellbeing, or a commitment to improve health and wellbeing, in our corporate plan. A brave move, because we don't have a statutory responsibility for health and wellbeing. Actually, we as councillors, you know, said, no, this is something we wanted to take forward because it's so important. It affects every part of our business, and having that right up there in our corporate plan, I think, helped members when they were lobbying partners. It helped officers. It was just the right thing to do. So, you know, if you take away sort of anything from this presentation, and you're a district council, check your corporate plan. If you've got a commitment in there to improve health and wellbeing, to look at the social determinant, have health in all policies, because it's crucial. It's absolutely crucial. And as you can see there, we're still moving on and on and on in our health journey. And, you know, hopefully we're going to be going from strength to strength. Grant, over to you.
Thank you, Councillor. So what I wanted to give you just perhaps some examples here at a tier 2 level. So taking that perspective as to perhaps how we are working in a different space. And very much aligned to our colleagues at County, of course, as to kind of how we're looking at implementing that health lens, that health for our services. So I wanted just to give, I won't go through every one of these, but I just want to give some examples here really as to some of the work that we're doing in this space. I mean, so as part of our health and inequalities approach, Basildon Council is aiming to shift perspectives. So all of its functions, whether that's litter collection or its facility management, its leisure green space development. I'm quite clear with all my staff that they do public health work. They do public health work to some degree or further, providing the places and the spaces where people meet and feel safe and want to stay active and want to participate in their community. So that's a really, really kind of key perspective that we try to put on our workforce. And I wanted to share, I guess, a few examples, I guess, where we've kind of we've put that health lens on things. So straight away, looking at some of what we've done with our staff. So this model here around human resources. We've been working recently very much I'm sure many people will recognise this, with the lockdown procedures. What we've seen is that huge elements of our staff have become very sedentary, where once upon a time they were actively travelling to the station and from the station to work and would pop out on lunch break, where we are, you know, like many councils, we're based in a town centre where you pop out for lunch and go and grab a coffee for a one-to-one and all of the kind of the good stuff. Well, people tend to be rolling out of bed and sitting at their computer and losing scope of when the day starts and when the day ends, and certainly have lost a lot of that activity, which of course has huge impacts on people's mental health. So we started to work with an organisation called Street Tag, and Street Tag uses gamification to create teams to get out on the street, to walk, to run, to cycle, and to win points over a 3-month leaderboard. Our first leaderboard was just finished across the community, not only for our staff, but across their community. We have over 20 million steps over a 3-month period, people participating. But we've been really keen to see how we can incentivise people to get up and move around during the day, take a break from the computer, look after their eyesight, look after their musculoskeletal condition, etc. So we've started to a process where people can pick certain times in the day to earn treble points, to get out there, go for a walk around the block, etc. So that's one of the ways in which we kind of try to put our lens on how we're trying to support our staff, but that also aligns to our communities and partners. And a number of our community health partners have joined Street Tag and have created teams as well, where they're competing with each other and their members, which is quite exciting. Councillor Gordon also spoke a moment ago about waste collection. So we'd noticed, and it was brought to the Health and Wellbeing Board, the fact that we were seeing huge record numbers of glass collection, and lots of those were beer and wine bottles and spirit bottles. So being a council that wants to take an active health lens and wanted to notice, those reports were coming back to our Health and Wellbeing Partnership saying, you know what, our refuse guys are collecting incredible numbers of glass recycling. It's gone up over 50%. So that enabled us to have conversations with our core health team to talk about what support we can get through our GPs and through the services in relation to people, and just generally asking questions around people's alcohol consumption. So really, really important ways of where you can find insight and data to be able to build a bigger picture. And the final one I want to pick up on this slide was just some of our procurement work. Again, we've moved from a situation where we're only procuring on who can provide us the most money, which, let's be clear, in today's day and age is very important, to what are the outcomes we want to achieve. So we're very much outcomes focused. So we've done some really positive work with some empty community space in our community, in our country parks, where we're looking at procuring on the basis of our corporate plan, specifically looking at around the difference that people can make by using our facilities around health and wellbeing. And from that, we have created, we managed to engage a series of local charities that are working to support our residents around mental health and around physical disabilities and the like, to be based in our community halls and to be based in our community facilities more. So they are now weighted to having greater opportunities to, and therefore supporting our local voluntary groups. So there's others, but those are some of the examples we wanted to share of how we've kind of looked at things a very holistic route to improving health for our services. And then I want to talk about some health for our partnership working. So I've given some examples here of some of the partners that we are working with as well. And it's very much looking at how we can work with our community partners. So BASIS are a sight impairment charity in Basildon. We've been working with those guys. We've provided a public health grant to them, but part of that, what we tend to find was happening for our Health and Wellbeing Partnership is that the grant was very transactional. We gave a grant, they said they were going to do something in a year. We said to them, send us a piece of paperwork to say whether you've done it. And that was great. But what actually did we learn as a partnership? And often what came back was the small micro funding, actually they felt quite isolated with it. So although we're giving out small amounts of money, what we also are giving out for our grants is quite large in-kind support. So we've created a buddy system with senior members of the Health and Wellbeing Partnership, whereby we give micro grants, but also you've got a buddy from within the group all year long. That group, that buddy will go along, have a cup of tea, meet with the participants, speak with them, try to kind of work out where we can feed them into the system, where we can help overcome perhaps some of their systemic issues with being able to provide the support they needed. And from that also, it's given us a chance for them to come in as almost providing, working with their communities as experts by experience. So from this sight impairment charity, they've been into our leisure facilities, into our customer service centres, and given our staff real insight of what it's like to work with, to be someone with a sight impairment coming into their facility, and how they can perhaps act better and for us be a better place. So some really positive examples there. We've been working with a fantastic organisation for many years called Sport for Confidence. Sport for Confidence are a group of, are run by OTs, and they are OTs that use occupational therapy to build physical activity into all that they do. And since we built our sporting village, which is our major leisure provision in our town, we've had Sport for Confidence there running from the beginning. Now, what's interesting about that is Sport for Confidence are not a hirer. They are a CIC, but they're paid for by our leisure operators who are in the private sector. We have a relationship with our leisure operators on a profit share. But what's been really clear is we're not interested in profit share for this. We're interested in the outcome it's going to deliver. So what we've got here is the voluntary sector working with the private sector and working with the statutory sector, or working with the public sector, I should say, to provide OT support in our leisure centres, which basically means that where possible, people are leaving a disability at the door and able to participate, not necessarily in standalone programs for people with disabilities, but actually in the mainstream wherever possible, working with the OTs. And that has seen huge rises in the understanding and the upskilling of staff across our leisure contracts. So we're really excited about that. The final point I wanted to make on this slide was in relation to an organisation called Motivated Minds. Motivated Minds bring health and wellbeing, and specifically mental health support, to the high street. They're based in our major shopping centre, where we have large footfall, and they provide all sorts of kind of services to the local community, whether that's classes, whether that's counselling, whether that's support, or whether it's even just providing services for those with dementia, so as families and carers can go out and do the shopping that they to do. Now, what we've done now, although this is running in a private sector operator, we have committed to providing a 0% business rates to them, because they are helping us meet our corporate plans around health and wellbeing. So again, it's just another example around how we can even look at business rates and our Revs and Bens team to be able to drive the health impacts we want to do. And that's the example of the health lens. So I'll just whiz through this because I'm aware we're coming up to time. Clearly, I've talked a lot about what we're doing here, but I really cannot pass this opportunity without sharing the incredible work that happens in our communities as well. And throughout the COVID response and wider, we have seen communities doing incredible work. And our role very much, again, for our lens, is to how do we better enable to do that, give them what they need, provide the support, but also get out of the way where we need to, because the communities have been incredible at stepping up with regards to supporting each other with access to food and medicines and befriending and all the things that I know that all of the authorities here are doing. But I thought it was really important to make it clear that when we talk about the partnership, this is very much in line with our communities also. Now, we're very ambitious in Basildon too. So we are very lucky that there are two major investment opportunities that are through the larger infrastructure and overarching bodies for sport and for art. The LDP, which is the Sport England's funding for helping the most inactive get more active in deprived communities, as well as Arts Council's Creative People and Places, which again looks at those that are most inactive but perhaps culturally inactive. So Basildon, I'm really proud to say, are pilot areas for both, which has enabled, and we've done that very much through looking at our health and wellbeing programme and how we can use that community and physical activity work through Sport England and that cultural democracy work through the Arts Council to bring people on board, get them participating in their communities, whether culturally or physically. And we know that people are happier, healthier, and more active with better mental health if they live in a place they like to live and are proud. So that civic pride thing is really important. So we're really grateful and really proud that we've managed to bring in many millions of pounds over the last couple of years to be pilot areas for the Arts Council and for Sport England. And our task now very much is how we align these pieces of work. And we've had a restructure within in our organisation generally to know that we are best placed to do that, aligning our leisure with our community work, with our cultural offer, with our public health work. So under our culture and health team, which I'm very proud to lead. So what you'll have seen here in these slides is that we talked here about how we have health for our services, health for our partnership working, health for our national programmes, and health through our community activism. And in essence, what that means is we try to take a health in all matters approach wherever possible. And that is what I guess we refer to as our health lens. Hang on, change. Doing that thing. Hang on, here we go. So very, very quickly at the end here, looking forward, we're in the process now of creating our connected community strategy. So how do we take that great work that was happening in our communities and ensure that it wasn't something that just happened during COVID and was a standalone. We need to make sure that this is standardised now. We're looking at collating all of the various micro funding opportunities and creating a triage process so we can see how we can take funding much further and help meet the health and wellbeing needs of our communities. We're in the process of developing a social value policy as well, actually, as a financial resilience policy, because these are so important. And then, Councillor Gordon, I'll let you take over for this last point here.
Yeah, just to finish. I mean, for me, the most exciting thing, we've got something going to committee tonight where we're hoping to, we're putting together money from a footballer, Mark Noble, who's very kindly donated his money, Countryside Properties and the County Council. We're putting together a fund to improve mental health and wellbeing in our community. That's just an example of how, by working in a different way, by promoting health and wellbeing, by talking about health in a district council, we can actually deliver some real change for our residents. And it's very exciting. And I want to extend an invite to anyone on this panel. If you're interested in the work that we're doing, if you want to have a chat, please just get in touch. We're really happy to speak to you. And thank you very much for inviting us here today.
Thank you, everyone. Thank you so much.
Thank you. Have you come on to me yet? Hi, thank you. That was really interesting, and I've been scribbling lots of notes to take back to our Health and Wellbeing Board, so that was fantastic. Thank you very much. Okay, so we're going to try and go back to Councillor Tim Hutchins now from Hertfordshire Council. So Tim, if you'd like to have a go, and hopefully, fingers crossed, your technology's working now.
Thank you, Louise. Is that any better? Oh, good. Right, good morning. As I say, firstly, thank you for the invitation today. I have to say, when the invitation came through, I was delighted, but a little questioning as to whether you've got the right person. I've been Cabinet Member for Public Health and Prevention in Hertfordshire since January 2019, and confess that when I took on the role, I knew nothing about public health. 20 odd months later, maybe I can claim to know a little bit more than I did in the first place. I say this not to highlight my own shortcomings, but to emphasise the need for getting the message out there loudly and clearly, that health factors are vital ingredients in developing our residents' well-being. From that, I hope you will recognise that I'm very much a convert and hope to make the case briefly for health in all policies. As a former deputy leader of a borough council and cabinet member for environmental affairs, a deputy cabinet member for education and libraries at county level, I think I can claim to have understood how things worked, but in an environment where delivering savings and efficiencies was important, I, like many others I suspect, gave little thought to the underlying immediate impacts beyond those of the decisions I was making. Having taken on the role, I was rapidly made aware of the fact that everything we as local authorities do impacts on the health and well-being of our residents. Whether it be through planning, education, the provision of recreational facilities, highways, or the multiplicity of other activities, the decisions we make impact in one way or another on the health and well-being of all our residents. On taking up my post, the first thing I had to do was to complete the development of our prevention policy, which thankfully, bar a few tweaks, had already been drafted. The essential messages in that policy are the importance of considering the health implications when making decisions, collaboration, focus on inequalities, and of course ensuring that decisions are evidence-based, whilst of course acknowledging the need to ensure value for money. The importance of considering health implications of our decisions may appear to be self-evident, but I'm not sure everyone sees it that way. I would argue that as we attach inequalities assessments to most policy proposals these days, why aren't we also attaching a health impact assessment? Before coming on this morning, it seemed to me a good idea to check on the definition being applied to health in all policies, and I apologise if someone's already done this, but I think it's important to go through it nonetheless. Health in all policies is an approach to policies that systematically and explicitly take into account the health implications of the decisions we make. They target the key social determinants of health. They look for synergies between health and other core objectives and the work we do with partners, and tries to avoid causing harm with the aim of improving the health of the population and reducing inequity. I was particularly taken with the reference "and tries to do no harm." Doesn't sound very ambitious, does it? It is, though, I would argue, an important point. The impact of place on health is important to us. As a council last year, we passed a motion declaring an environmental emergency. And I'm pleased to say that our public health team is playing an active part in developing the strategies that are arising from it. We think that this is a clear example of an approach to policies that systematically and explicitly takes into account the health implications of the decision we and others make. If one accepts the importance of place, and I do, I pose one key question. Why is it necessary to include an assessment on health, why isn't it necessary to include an assessment on health and well-being of residents when considering planning applications? Unfortunately, our planning health service has no statutory planning functions. It is not a statutory consultee in the planning process. This means there's no legal requirement for planning authorities to consult us. Frankly, I think that's a nonsense. It therefore follows that we have no statutory duty to respond to planning proposals or applications. Nonetheless, we in Hertfordshire feel it's important to do so. In Hertfordshire, we put in place a strategy that states we will comment on all planning applications over a certain size, where we have specific concerns. Clearly, we can't engage on every planning application, so we focus on those we consider to be of sufficient size, scale, or type of operation. Normally, if it's to do with housing, 100 dwellings and larger. The general guide is that we will look at all sizable applications, but may form an opinion where other factors come into play. For example, a small development for the elderly, where the site is, in our view, one that is inappropriate. As stated above, we have no powers, but we do have influence, and will recommend that health impact assessments are undertaken on all major plans, policies and development proposals. We will also recommend that all plans, policies and development proposals have regard to our own planning, health and wellbeing guidance. If we consider it necessary, we will also consult independent experts such as the environmental scientist at Public Health England to help inform, advise or provide external review of our conclusions and advice. As an example of with regard to collaboration, as you will all know, a cross-cutting requirement, sorry, I'll go back to that one. Collaboration, as you will all know, is a cross-cutting requirement in many parts of our work if we're to be successful. That has perhaps been no more evident in our efforts to tackle the current crisis. Apart from the operational benefits arising from it, I think it provides a good example of how effective consultation between stakeholders and partners can enhance the outcomes we all seek. There are many examples that I could talk about, but if I were to pick one, it would be our approach to dealing with outbreaks following the first wave. In developing policies with our 10 district and borough colleagues, we've been able to agree common purpose in our efforts to protect the health and well-being of our residents. Not something that you would think would be difficult under the current circumstances. But in doing so, we have effectively agreed a common approach to shared resources using the synergies between health and core objectives in the work we do with partners. I have always taken the view that in public health there is plenty of work to go around. So it's better that we get on with delivery rather than wasting time arguing about who does what. To achieve this position, we have needed to work on developing a spirit of cooperation and trust, which, although from time to time we have to confess gets tested, our work in supporting our districts and boroughs in developing the initiatives, which, for example, has enabled them to introduce health hubs into each of their areas, has been extremely helpful. Over the past 3 years, we've invested 2.3 million in doing so. Each district has been allowed to tailor their hub to meet their local needs.
Tim, I'm sorry to interrupt. We've lost you again. Tim, I'm really sorry we've lost your, and it was so interesting. We've lost your audio again, so sorry about that. We're probably going to have to meet on it. It was just in the last minute that it's just gone completely. So really sorry about that. But it was great to hear about, particularly about the stuff you're doing around planning. That's great. So if I could now move on to Louise Marshall. Louise is a Senior Public Health Fellow for the Health Foundation. Thank you very much, Louise.
Thank you so much for inviting me. Now I'm going to, always makes me a bit nervous pressing this share screen button. Hopefully this will work. Okay. Slideshow. Can you see my first slide? Great, super. Thank you so much for inviting me to speak today. I'm just going to work out how to move this on. A senior fellow at the Health Foundation. So we are an independent charity focused on health and healthcare for people in the UK. So I work in the Healthy Lives team at the Health Foundation. And our work looks beyond healthcare to the wider determinants of health, or social determinants of health. All of those things that shape where and how we live, we learn, we work, and we play. So our aims in our Healthy Lives strategy is to change that conversation about health to focus on the role of health as an asset for society and the economy, rather than thinking about the burden of ill health, as so often dominates the narrative about health. And through our work, we promote policies and encourage local action to improve opportunities for a healthy life in the UK for everyone. So consideration of health and health inequalities across policies and actions of the different sectors. So I've been asked to talk today about some of our recent work at the Health Foundation on health inequalities. I'll first set some of the context that the COVID-19 pandemic landed in, but focus mainly on some of our work then over the past 6 months on the unequal impact of the pandemic on health. So this slide shows an infographic we've produced about the wider determinants of health, or social determinants of health. And this infographic, together with more detail on each of those individual determinants, is all available freely on our website at the link at the bottom, together with this quick guide introduction to the social determinants of health. So all of these things in that diagram, our work, our surroundings, our financial situation, our housing, education, what we eat, how we travel, who we live and socialize with, they all act together and interact to determine and drive our health in many different ways, and differences therefore in each of these determinants drive the inequalities in health. So just to set the scene now, I will talk a bit about some of the health inequalities in the UK prior to the pandemic. So this slide, which I'll talk through, it's quite similar to the slide that Alan showed earlier, but zoomed in on a slightly more recent period from 2001, and it shows trends in life expectancy, depending on how deprived the area a person is born and lives in. So as we've heard, throughout the 20th century, the UK experienced some steady increases in life expectancy, but these improvements slowed and in some groups completely stalled over the past decade. So these two charts, which are taken from the Marmot 10 Years On report that we commissioned the Institute of Health Equity to undertake, and which they published in February, just before the pandemic, shows this slowdown in improvements since about 2010. If I can put, yes, about this point, about 2010. So the chart on the left is males and females, so very similar patterns, but both starkly illustrate those wide inequalities in life expectancy, where the top green lines in each chart represent males and females who are in the least deprived fifth of areas, and the grey lines at the bottom are those who are in the most deprived fifths. So the gap in life expectancy on average is around 8 years, and that's simply due to where a person is born and where they live. So the slowdown since about 2010 has brought no closing of that life expectancy gap, and in some cases you can see there, I think particularly in women, this gap has widened over recent years. And if you live in a more deprived area, not only can you expect to live a shorter life, you can expect to live a greater proportion of your life in poor health. So these charts show healthy life expectancy, which is a measure of the number of years that a person can expect to live in good health. And it shows the lines at the top, so it's on the left is women, on the right is men. And the lines at the top, the blue lines, represent the least deprived tenth of areas, people in those areas, and the red lines at the bottom are people in the most deprived tenth. And then along the bottom axis, you can see on the left it's 2011 to 13, and then over to recent years up to 2018. And you can see that huge gap in healthy life expectancy has increased over that period and now stands at just about 19 years for women and just over 18 for men. So however often I show this chart, it shocks me. So the role of local government in addressing the wider determinants of health and therefore tackling some of these health inequalities is very clear. But as you're all too aware, local government budgets that are needed to do this have been subject to huge cuts in recent years. And something we know is that these cuts have been greatest in the most deprived areas, so the very places where action on those wider determinants is most needed. We also know from some Health Foundation analysis we carried out on spending on children's services that in the context of these cuts, the pattern of spending has also changed. So a smaller proportion of total spend has been on preventive services. So in children's services, that includes things like Sure Start and early years services. And these are services that we know can help tackle health inequalities. And a greater share has been on more reactive services that have been responding to increasingly more acute needs. So understanding that role of health as an asset for societies and economies, and understanding that impact of all sectors on the health of populations can support that case for action on the wider determinants. And as Councillor Gordon said, recognising that health affects all of our business as well as all of the business of local government affecting health can help make that case. And we've heard some great examples so far of actions that approach and that mindset has led to. So moving on now to some of the unequal impacts of the pandemic. It's really into that context then of increasing health inequalities and decreasing local government budgets that the COVID-19 pandemic hit us. And this was never going to be a great leveller. So back in early May at the Health Foundation, we published a piece setting out the ways in which we expected the pandemic could be a watershed moment for health inequalities. And that without mitigating action and consideration of the really broad health impacts of both the virus and our response to the virus, the pandemic would certainly exacerbate pre-existing inequalities in health, as well as introducing new ones. So since then, over the last sort of 6 months, we've been collecting evidence, doing some of our own analyses, and also commissioning research on the unequal health impacts of the pandemic. So I don't have time in the remaining few minutes to go through all of the ways in which we know so far that the pandemic has unequally impacted health so far. But what I would like to share with you first is a framework that we have been using to help us think about this, which I hope you'll also find helpful. And then I'll just go on to highlight a couple of the groups that emerging evidence tells us has been hardest hit so far. Oh, sorry, I didn't realize this slide did this. There we go. I think it's all there. So with thanks to my colleague, Tim Elwell-Sutton, for this slide, I'll take you through this, this framework first. So over on the left, the two grey arrows, we have these two enormous forces that have hit us. So the COVID-19 virus itself, and we're sadly all too aware of the health impacts of this. And also on the left, there is the government and societal response to the virus. So there's significant measures that we've had to take that have disrupted pretty much every aspect of people's lives and involved, as we know, the shutdown of significant parts of the economy. So the two red circles over on the left there, they represent our starting points, I guess, where we came into the pandemic, and our experience of the pandemic and the impact it has had on us is strongly determined not only by our prior health, so we know, as we've discussed, that's subject to huge inequalities, but also by our personal, social and economic circumstances that includes our housing, our jobs, who we live with, where we live. In the middle then, we've got on the top the direct health impacts of COVID-19. So that's largely based on those things in the red circle. So some people are more exposed to the virus. Some people are more at risk of serious outcomes if they do catch the virus. Some people are more at risk of direct mental health harm that we know is happening. And there are also the impacts of delayed or disrupted treatment for other pre-existing conditions. So people may be presenting later. Some services may have been paused as health systems deal with the pandemic. And then at the bottom there, we've got the social and economic impacts of the pandemic. So many people have lost their jobs and or income. Educational institutions and many industries were shut down. Communities have been disrupted, and the impacts of these things will be with us for many years to come. We know that health is impacted in the very long term and by these social and economic factors, and these impacts will strongly influence future health and health inequalities in our populations. So I'm just going to go on now to speaking briefly about some of these unequal health impacts of the pandemic. So firstly, back to deaths. This chart shows excess deaths in the UK, which is the red line over the period of the pandemic when it was at its peak in April, in the middle there. And that's compared with the average of the previous 5 years, which is represented by the grey line at 0% there. So while many of these excess deaths we know are due to the virus itself, not all can be attributed directly to COVID-19. So included in that line may include deaths from disrupted treatments for other conditions, from also some of the mental health impacts of the pandemic, as well as any increases in other causes. And lots of work's underway to better understand what has driven that, as well as the virus itself. But what we do know already is that not all groups have been equally affected. So this chart, sorry, it's all a bit small on there, but I'll talk through it briefly. This is a chart from the Office for National Statistics that was released in late August. So it shows deaths month by month. So we've got March, April, May, June, July along the bottom there. And the first two bars, so the sort of middle blue bar and the yellow bar, show all causes of death. And in the blue bar, that's in the most deprived groups, people living in the most deprived areas, and the yellow bar is those in the least deprived areas. So you can see between the blue and the yellow bar, there is huge inequality in deaths from all causes. The second two bars, the dark blue bar and the sort of light turquoisey bar, show deaths from COVID-19 in firstly the most deprived, and then in the light blue, the least deprived groups. So you can see that there is also inequality in deaths from COVID-19, particularly apparent in April there, which was really the peak of the pandemic and the peak of deaths in the UK. There has also rightly been a lot of focus on unequal health impacts of the pandemic on people from different ethnic groups. So it became clear from the very early stages of the pandemic, this is a chart showing deaths up to middle of April, that the risk of dying from COVID was very different for different ethnic groups, and risk being particularly high, as you can see here, for people of Black and of Bangladeshi or Pakistani ethnic groups, who are many times more likely than people shown by this line here, of white ethnic groups to die from the virus. So there's a lot of research underway to really fully understand the reasons for all of this, but it does reflect some of those pre-existing health and socioeconomic inequalities, and likely both a greater likelihood of catching the virus due, for example, to being a frontline worker or living in densely populated areas or housing, but also worse outcomes if you catch the virus, including due to pre-existing conditions. So nearing the end now, just looking at some broader health impacts of the pandemic, and this shows mental health. So we know there's a very strong link between our economic circumstances and our health, and there's been very alarming evidence about very immediate impacts on mental health. So I want to really make 2 points from this chart. So firstly, looking at the red bars, this shows the share of the population with poor mental health, so this is the adult population, by family income quintile. So over on the left, you have got the fifth of families with the lowest incomes, going as you move to the right of the chart, those with the highest incomes. So you can see that there is a gradient in poor mental health, with higher prevalence of poor mental health the lower the family income. But then in the blue bars, there is adults whose family financial situation has got worse during the pandemic due to potential loss of work and or income over the period of the pandemic. And so this was in May, asking people to compare their mental health to pre-pandemic times. And you can see there that those people who have had a worse financial situation due to the pandemic or during the pandemic have poorer mental health across all income quintiles. But again, you can see that that very clear gradient. So those people who were worst off in terms of the mental health impact are those in the deprived areas and those whose situation has got worse during the pandemic. So emerging evidence tells us that certain groups of the population have been more affected than others financially, and so we expect some of the greatest health impacts to be seen in those groups. So firstly, some of the people who were on lowest incomes before the pandemic have also been those who've been hardest hit financially, so often due to working in sectors that were shut down, such as hospitality and retail. We also know, again, for some of those same reasons, that young people, especially those aged 18 to 24, are more likely than other ages to have lost work and or income or been furloughed during the pandemic. And then also we know that women are more likely than men to have taken on more caring responsibilities while schools were closed, often with a negative impact on their work or their income, for example, due to being furloughed or in some cases asking to be furloughed. So just to finish off now, while evidence has been coming quite thick and fast, and we've published sort of monthly blogs over recent months that have rounded some of this evidence up, which are all on our website, there's still a lot we don't know. Much research is underway, but much more is needed. And next month we will be launching our COVID-19 impact inquiry. So this inquiry aims to comprehensively synthesize evidence to date on the health and health inequality impacts of the pandemic. That will include how people's experience of the pandemic has been influenced by pre-existing health and inequalities, and also how the likely impact of actions taken in response to the pandemic, how that's impacted health and inequalities. You can sign up if you'd like to hear more about the inquiry and updates from the inquiry as it progresses. It's due to report next summer at this link. And I will finish there. Please do get in touch if you wish to, and you can find our work on COVID, including the emerging evidence blogs, collated on this page of our website. Thank you. Stop sharing my screen.
Thank you, Louise. There were some very startling and sobering facts that came out through that, and I think it gives us an idea of the scale of the challenge that we have going ahead. And thank you to all our speakers. So now we're over to the Q&A session. And we've got the first 3 questions that we're going to ask. So the first one, and I'm going to ask either Andrew, Tim or Alan, because it's sort of a council related one. So in your experience, what are the most effective ways of strengthening joint working with partners in the NHS? So if one of the Alan, Andrew or Tim want to come back, or all of you can.
Yeah, I mean, it's something I feel very strongly about, because sometimes I just felt like banging my head against a brick wall when it comes to working with the NHS. You could literally have an open door and say, come in this way, we're going to help you with all your health problems. You know, this is where you go. Yet getting them around the table is a nightmare. I found I had to do 2 or 3 things to really sort of get them around the table. One, send letters, you know, from Councillor Gordon saying, come to our meeting, really lobby them hard, and lobby the, you know, the chief executive of the CCG, the chief executive of the local health trusts. You know, that lobbying was key. Meet with them if they don't attend. So if a healthcare partner or someone from the NHS is not attending a meeting that they need to be at to talk about some of these really important health and wellbeing issues, I will go and meet with them and I'll say, why didn't you come along to this meeting? You know, why wasn't you here? It was really important to have your voice at the table. The third thing is making sure you're getting the right people around the table. The NHS is a massive, complex beast. And, you know, you have to gauge what person from the NHS needs to be at what meeting. You know, if you're getting a frontline nurse, their experience is going to be very different to a commissioner. So working out where you target or who you target is just as important as targeting them in the first place. Sometimes I felt like it was a campaign. It was a campaigning issue that I, as a member, took up. I also think there's a lot for our officer corps as well. But you know, I'm not speaking too much about that because I don't have experience of that. But yeah, I think from my perspective as a member, that banging on the door, that sort of targeting, that sort of relentless campaign to get them around the table and open up those conversations, that's yeah, how I rolled.
Thank you, and I agree with you, Andrew. It's a long journey, and we've been on it for quite a few years now, and I think we've got to a really good place, actually. So don't give up. Keep on. Alan, you've got your hand up.
I have, and I'm going to put my NHS hat on for this as well. So, having been an NHS employee for 20 odd years, I'm very proud of all that time. And working then in local government for half a dozen years was a great experience. I'm very proud of that work too. And I certainly agree with what Andrew was saying. Remember that the NHS is not one body. It's got so many partners even within the NHS. So bear that in mind whenever you're approaching the NHS. And I suppose the only thing I would add is that when I've been looking at partnership working, one of the things I keep in the back of my mind is that you have to make everyone believe that they are a leader whenever you're talking to them, and that they are leading on their own particular dimension of the work. And of course, that is actually right. They are leading their own particular perspective on whatever that issue happens to be. It may not be the one that you particularly recognise, but I think some of the success in partnership working is recognising that everybody is leading to some extent on that area. So it is definitely worth doing. The rewards are not always immediate, but it's worth persevering.
Good, that's coming out loud and strong, isn't it? Persevere. Tim, if your microphone's working, do you want to come back in on anything? Okay, I think we might have lost Tim. Louise, do you want to comment at all? No? Okay, that's great. So, next question. How does health fit in with the local community crime scrutiny panel? We call it a community safety partnership, but it's probably the same thing, or the violence reduction unit to tackle risk factors for crime and disorder? That's quite a tricky question, that. Alan or Andrew, I don't know if you can help with that. So where does health fit into the crime scrutiny panel, community safety partnership, whatever you're calling it locally?
I think the answer is quite short and sweet. It fits in very well. And it's absolutely should be at the heart of any community safety partnership, should be how they're tackling some of the health and social problems. In Basildon, we invite the police along to our meetings. We invite our community safety team along. So there's that conversation. But I don't think you can have that conversation around health if you don't include community safety. It doesn't make sense if you sort of separate the two.
Okay, Alan, do you want to add to that?
Not much to add. That sounds like very good practice. I suppose I would just add that health colleagues ought to know that that's an invitation they should take up. That we need to have that perspective from the health service on crime support partnerships and violence reduction units. So should that invitation come through, please take it. Set aside other priorities and do contribute to that work.
And the police tend to have a bit more money than us, so it's always worth trying to tap them up if you can find that angle. Hopefully there's no police crime commissioners in the room or listening, because they might have a word to say. But yeah, definitely try your luck, definitely.
Louise, do you want to come in?
Yeah, so through a lot of our work, we're very interested in systems approaches to the wider determinants of health. And once you start to take that perspective of the system and think about how the determinants of crime, the impacts of crime, the determinants and impacts of health sit together in that complex system, that really tells us that these things are so inextricably linked and can't be separated, and thinking about how they interrelate is so important to the approach, and I think really engaging the breadth of sectors that need to act.
Thank you. Now there's a comment, and this is rather than a question, it's a bit of quite controversial maybe, but let's have a look at it. So it says, would be interested in how we frame health in all policies. How to ensure that we don't continue to focus on lifestyle issues, but rather the causes of the causes. Was reading some journals suggesting that dropping health might help the cause and focus on equity and equality and could be more successful. This may resonate with colleagues in councils. So I'll start with Alan this time.
Thank you. I saw that question challenge when it came in, which is a very interesting one. So you'd be looking at equity, equality in all policies. It's up to you in your local situation to work out what's going to work best. If you stick with health in all policies, that has that multinational resonance. It has a history to it, which will bring some people into the discussion that perhaps starting out with a focus on equality and equity might turn them off. I don't know. You'd have to assess it locally. What I recognised in the challenge as well was that potential to drift into looking at lifestyle and behaviour. And certainly that's something that we would want to avoid, and that the health and all policies approach should be something that goes right away from that and gets into social determinants of health. The only way you'll keep a head on that is to be conscious of what is happening. If it is drifting into lifestyle discussion or behaviour, then get it back on track. My personal feeling is that I wouldn't go for that overall change in the communication of the approach. I would stick with health and all policies. That has some resonance for me. You can bring in equality and equity under that heading still, I think.
Thank you, Alan. And Andrew, anything else you want to add? And then I'll come on to Louise.
No, just very, very briefly, I think it's important to keep the health tag, because I think that is the vehicle to bring partners around the table. But how you pitch that is the key thing. And you have to know your audience. You've got to know your audience. If it's the police, it's community safety. If it's perhaps the council's finance department, it's finances. Find your pitch, find your in. And then sort of drive health straight through it. But you've got to find your pitch. You've got to find what angle works.
Thank you, Andrew. Louise?
So again, a bit of a plug here, but we've been working with the Frameworks Institute over the last couple of years on this very point, really, that understanding what we as professionals mean by the wider determinants about health is not always the same as what everyone else thinks about when they hear the word health. And we know that there's a very sort of individualistic and medical model in people's minds about how they understand what's health, and therefore what determines health. So it's research that's underway, but there's information on our website, and I can share links if people would be interested, really to help understand, firstly, how people are thinking about health, but also how to reframe that conversation and how to talk about health in that way that doesn't take people immediately to those mental models of these sort of lifestyle behaviors, and both words that we don't like, that immediately come to mind, and individual responsibility, but help them to think about and understand the wider determinants and the societal responsibility for health.
Thank you, Louise. That's very helpful, and look forward to sharing the link so that everyone can access that information. So Louise, this is a question for you. Why are people from BAME population disproportionately affected compared to others, and what are the underlying reasons?
So, huge question. There is a lot we don't know still, and there is a lot of research underway to better understand that, but likely due to a number of reasons that are very linked. And if you think back to that framework I put up, and those red circles that show our sort of personal circumstances, so our pre-existing health and health inequalities, and we know that people from Black and Asian and minority ethnic communities are often more likely to have pre-existing health inequalities, health conditions, which then predisposes them to more serious outcomes of the virus should they catch it. There is also theories about where people work and their likelihood of being exposed and catching the virus in the first place. So that may be through workplaces, or being a frontline worker, or working in a sector that continued throughout lockdown. So potentially in healthcare or in other service industries. And also how much we come into contact with people in our day-to-day lives. So if we live in more crowded housing, and we know some ethnic groups live in larger households or in more crowded housing and are more likely therefore to be exposed. So a range of interlinked factors that are very difficult to disentangle and act together. But yeah, basically sort of how likely they are to be exposed, and also how likely they are to have adverse health impacts due to pre-existing health and socioeconomic inequalities that exist.
Okay, thank you very much, Louise. One final question, and it's a quick starter for 10. There's a question come in about neighbourhood policies, and somebody has put, we're finding that many of our volunteers are no longer available because they've gone back to work. And is this an issue in other authorities? So Andrew, is that a challenge? We're facing that challenge. So
I think, Grant, I think you'd be best placed to speak about this, because this is something that's your,
Yeah, thank you, councillor. The honest answer is yes. A perfect storm obviously happened a few months ago, whereby lots of people had more time on their hands, and there was a national call, everyone's moment to step forward and help out as a community, and now that clearly is lessening. What we have tried to do is to recognise that we're not going to be getting the same numbers of community volunteers, but then to perhaps work with them to say, okay, then now you've kind of got a bit of you've seen how you can help and the difference you make, and there's a bit of a buzz out there. How actually can we retain you in what way, and that can suit you? So we are very much looking, I mean, across Essex generally, but in Basden as well. We work with the lottery to help draw down funding from them to hugely enhance the volunteer centre that is run by our CVS. So we brought in another £58,000 to do that, working with them, which was a real positive. And part of that was really about how we could digitalise the offer. So almost get more involved in micro volunteering, so people volunteering more on a one-to-one basis with their communities, rather than volunteering for this one set offer where we need you to fill this job description, and therefore if you can do that then we want you, and if we don't, we don't, which obviously is hugely important to the way the voluntary sector works in many ways. But what we tend to find is that most people are volunteering on their own terms, and actually, was it volunteering or was it actually just neighbourliness? And that's perhaps where we wanted to unlock more, was just that I'm going to go to the shops, next door neighbour, do you need anything on the way? Because I know your mobility is not great. I'm not quite certain why a pandemic led us to do that, but we're all human beings, and so we've been trying to kind of encourage that to happen more. I think I have a nervousness of a second lockdown and having lockdown fatigue. And I think so that is a concern, and that was part of the reason why we wanted to work with our CVS to be able to build their capacity. We did rise to the challenge with lots of our partners working together on what we call our community hub, and we've not let that go. So we're going to continue to work in that way. But yes, it is a concern, but I would say focus very much on the neighbourliness side of things, what you can do in the streets where you live. People very much galvanised around the streets and the areas they cared about. We're geeks for local government. We talk in ward boundaries and in borough boundaries. Communities aren't talking like that. They don't really know what that is. They don't really care often. So focus on the areas that people really care about, and look at that micro volunteering. Would be my advice. Thank you.
Thanks very much, Grant. I'm afraid that's all we've got time for today, but maybe a future webinar, a topic could be around volunteering. I don't know if that's something that the LGA have got planned, but I know it's an issue we're all facing. And if we do go into a second lockdown, I think Grant's observations are correct, and we may struggle to get people volunteering in the numbers that we had in the first time round. So thank you all, those people that have attended. There's lots and lots of links for you. The webinar will be available in 48 hours, as will the slides that everyone's been sharing. There will be a survey, as you get with all of these events, to see how we can improve it. So thank you all. Lovely to meet you virtually, and stay safe. Goodbye.
Thanks very much.
Thank you, everyone. Bye.
Thank you. Bye. Bye.